Hello, everyone. Thank you for joining us for our Facebook Live session about maternal mental health. Leading our discussion today is one of our high-risk OB doctors and preeclampsia researcher, Mark Santillan, clinical psychologist and director of the Women's Wellness and Counseling Service here at UI Hospitals and Clinics, Stacey Pawlak, and patient advocate and president of EndPreeclampsia, Inc., Kara Boeldt. Dr. Santillan, Stacey, and Kara will be discussing some of the women's wellness services that we have at our hospital, explaining how perinatal diseases like preeclampsia can either result from or be caused by mental health issues, and they'll also bust some myths about mental health before, during, and after pregnancy. This will be an interactive broadcast, so please feel free to leave a comment below. We'll get to as many of the questions as possible throughout this live stream. One reminder tonight before we begin, our experts will be answering general questions, but this live broadcast is not intended to replace a visit with your doctor about your specific condition or symptoms. Now, let's meet our experts.
Hi everybody, I'm Stacey Pawlak. I am super excited to be here tonight, and I really want to thank Kara and Mark for inviting me to this great discussion.
Hi, I'm Mark Santillan. I'm a high-risk obstetrician, and I do research in preeclampsia, and I'm very fortunate to be surrounded by these lovely ladies who are a lot smarter than I am about a lot of things, so it's great.
Hi, I'm Kara Boeldt. I am one of the admins at Preeclampsia, Eclampsia, and HELP syndrome survivors, a global support network for women who've had hypertensive disorders of pregnancy.
Great. So let's get started with some of the questions that we received. A common theme we saw in many of the questions submitted ahead of time was grief. Nisha asked, how do you deal with grief and trauma following severe preeclampsia, causing the loss of baby and nearly the loss of your own life?
So, Nisha, thank you so much for giving that question. And I think that traumatic experiences like that often do lead to PTSD. Not always. Trauma doesn't always lead to that, but it frequently does. I think it's really important to talk to people about the experiences that you have. Talk to a professional if you can, and give yourself the time to deal with what the symptoms that you might have. There's a lot of really good resources that you might find on the APA, which is the American Psychological Association site, that give good ideas of what to do with PTSD, what types of treatments help with that, what types of things help with grief and trauma. That's a really good place to look for ideas on how to treat that.
Please.
We've found within our group, and Nisha, I know you're a member in my group, having a place where you can meet other women online who've had similar experiences to you and talk about that, just so you know you're not alone in the grief that you're experiencing, can help a lot.
And if this, and it seems like this is something I say a lot to my patients, and I think it's really important for everyone to realize that this is not your fault. This is nothing you did. It was a bad set of cards that you got. And I think that stops a lot of people from recognizing their symptoms, and it stops people from seeking the appropriate professional help that they may need. So I think the most important thing that you remember is it's not your fault. Be cognizant and understand the type of symptoms that you're having, and please find help where you can.
Great, those were great answers. The next topic is, it can be difficult to cope with a second pregnancy after experiencing a traumatic pregnancy, childbirth experience, or NICU stay. So how can expectant mothers manage fears, panic attacks, or depression in a so far healthy pregnancy following a challenging perinatal experience?
I think one of the best ways to do that is to have a really open conversation and dialogue with your care providers about how you're feeling, your fears, your anxiety, your nervousness, and be as specific as you can. Ask for their input and their help. And if you don't understand something that they've told you, or they maybe don't seem to take it as seriously as you'd like them to just stop the conversation and say, hey, look, this is really concerning to me. You don't seem to be as concerned. Can you explain to me why you're not concerned like I am? That can give some really great insight, and it really helps your doctor to stop for a minute, take a moment, and to cover those issues with you, so you can feel at least like you're heard and that they are looking out for you.
I think one thing to remember is when you go through something really difficult or traumatic or challenging, you're primed to expect that. When you're in similar situations in the future, you just feel like it's going to happen again. It doesn't necessarily mean that it will. Like, the likelihood of that thing happening again isn't any greater, but it feels like it is. That's still important, but it doesn't mean that it actually will happen. So, but I know what that feeling feels like.
You almost, and just to kind of piggyback off what you're saying, it's really hard for you not to feel that way. It's really hard for people like, I had preeclampsia before and I had resultant postpartum, or I had postpartum depression afterwards, that you're just with this next pregnancy. And the thing that I challenge myself and my colleagues to do is to try to encourage people to enjoy their pregnancies. You know, we're here as medical professionals to help you get through your pregnancy, whatever that means, from the physical end to the mental end, everything. And I think being, as everyone's already said, being cognizant of all of your symptoms and being able to intimate that and tell your care provider that these are serious, these are important things to you.
So Erica asks, is it possible for our partners to suffer from PTSD from a traumatic birth experience and or a NICU stay? If so, how can we ease our partners' minds about having another child or help them with their PTSD related to childbirth?
What's the take? You know, I again, as someone who is fortunate to deal with a lot of families and try to shepherd them through a lot of difficult pregnancies, often the partner gets kind of left out. And I think it's an excellent question to remember, like, what do you do? And again, it's knowing your symptoms, knowing that something doesn't feel right, and really advocating for yourself. When I see these patients in my practice, and I see them in my clinics, and I'm starting, you know, and mom tells me, you know what, there's something wrong with him, and we quickly glom onto that and send them to people like Dr. Pawlak for appropriate care.
We see this come across as, my husband doesn't want to risk another pregnancy, even though we thought we would have, 3 kids after this first experience. He doesn't want to have any more kids. He's fearful for me. He's fearful for future children. And my usual suggestion is take him along to a preconception consultation with an MFM like Dr. Santillan here, and have that discussion up front. What are the risks, right? Lay them out in black and white so that you guys can make an educated decision about what that future looks like. And, if you are yourself like in therapy, bringing, your partner along, and setting that up with your mental health professional can help too. And you can have that, discussion with your partner as well.
I absolutely think that partners and non-caring, husbands and non-caring partners can experience all the same sorts of feelings, depression, anxiety, grief, trauma, PTSD, that the caring partner did. It may look differently sometimes too. It may feel differently, but on the inside it feels the same usually. I usually try to say that just trying to go back and remember what the reasons were to kind of build the family, like what were the hopes and dreams. At some point, getting back to that, hopefully that gets around the fear that came about from whatever traumatic experience occurred, NICU, preeclampsia, any kind of trauma like that.
I think oftentimes the fears are, greater than actual risk factors.
It's true.
And so by, getting the evidence, getting that figured out can help make that decision easier.
And in our environment of being able to get information just like this off of our phones, off of the internet, it's hard to kind of siphon all of that data. And there are myths out there that need to be debunked and need to be discussed. But I think there's nothing that will supersede being able to just talk openly with your providers, as we've said here.
Yeah.
If you're just joining us, we're here with high-risk OB doctor and preeclampsia researcher Dr. Mark Santillan, clinical psychologist and director of the Women's Wellness and Counseling Service, Stacey Pawlak, and patient advocate and president of EndPreeclampsia, Kara Boeldt. We're discussing maternal mental health before, during, and after pregnancy. This is an interactive video, so please feel free to leave us a comment with your experience with mental health, preeclampsia, or other perinatal disease, or ask our experts a question. We'll be answering as many of them as possible. And please feel free to tell us in the comments below where you're watching from. So the next section is going to be about myths, because there are a lot of myths and misinformation out there about mental health during and after pregnancy. So comment with your questions about this topic, and we'll be happy to bust any of those myths for you. Let's start this portion of the discussion with the following question. Can I still take my antidepressant or anti-anxiety medications during pregnancy and while breastfeeding?
Please. Oh, was that too fast? As often somebody who is, the person counseling these patients, absolutely. There are some that are safer in pregnancy, but that requires a discussion with your provider. The fear is that a lot of times the fear overwhelms the right thing to do sometimes. And I have a lot of women in my clinic who said, I have had long-standing anxiety. I'm on all of these medications. And I said, I got pregnant and I went off of them, and I go, I'm like, Stacey, Dr. Pawlak, please help me. And so a lot of these things are, and we get it. You're concerned about your baby, and that is natural. But we also have to take care of you. And so I think that's very important. Since we're in the myth-busting section of our discussion, as the resident statistics geek, my PhD is in stats and epidemiology, and so some of the there's one thing as we've been looking at the questions from Facebook, some of the things that seems difficult to kind of connect is the idea of causing preeclampsia or being associated with preeclampsia. And I think it's a really important thing, especially in the world of Dr. Google, right? And so just to discuss that just a bit, just because a particular study says this is associated with preeclampsia or this is associated with preeclampsia and mental health, doesn't mean it's causative. For example, we've all just come back from the holidays, right? I visit my family every holiday. Amazingly, my pants are just a little bit tighter, okay? So that doesn't mean visiting my family causes my pants to get tighter. It's the causative effect of me eating too much during the holiday season, right? So that is that's the cause. The association is the fact I just happen, to be visiting my family and eating too much. And so it's this idea of what is actually causing. To get to the true causal root of a lot of things, particularly preeclampsia and mental health, it takes a lot. It takes models, it takes basic scientists and all that to get to the true cause. And so when you see something and you see a particular chemical that's associated with preeclampsia and say, oh my gosh, that's in my carpet, am I going to get preeclampsia? A little bit of that is, it's almost reassuring to know that it for the most part, you're not gonna, it doesn't put you at risk, 100% risk of getting something. So I hope that makes a little sense in terms of making that distinction. So, sorry.
I was going to share something. So I work in a clinic where all of us are specialists with perinatal mental health. And recently one of our psychiatrists gave a lecture on medications during pregnancy and breastfeeding. And I loved what she said. She said, we want mom at her best. And I mean, that really covers it. If mom at her best is not on medication and she's doing well, that is awesome. But if mom at her best is taking medication, then that's what needs to happen. And there definitely are medications out there that are going to be good ones to help mom stay healthy, take her prenatals, not use substances because she's feeling down or whatever during pregnancy. The risks that come with untreated mental health issues are significant, so you really have to weigh those when you're thinking about medication or not. So that's really important. And talking to professionals, including OB-GYNs, about that is really, really important before you decide not to take medications. We see that all the time in our clinic where they come in, they're like, nope, I'm not taking it. And they're miserable. So I'm a therapist, so I love non-pharmacological treatments, but I do know there's definitely a place in the treatment program for medications.
Go ahead.
I think society has just told us that birth is natural, and that women have been doing it for millennia, and you should be able to do it, and that medications are bad. And I think they don't realize that there are consequences and side effects to not being treated for things. Like, you wouldn't not take your insulin if you were diabetic,
Right.
because you're pregnant. You would take that so that you can be healthy. And I think it's the same for medications that you take for any, sort of mood disorder as well. And, just have that conversation with your doctor. Is this medication safe? I read on Dr. Google that it's a category whatever, and is this okay to take? And I say, if you don't trust your doctor, you might want to find another doctor for a second opinion. You can always ask the pharmacist, right, to have that discussion with them as well. So definitely talk to your doctor about it.
Do you ever use mothertobaby.org? Do you use those handouts with your
So
patients?
we have some, not as commonly. A lot of times what we do is, there's so many new medications out there. So I'll tell you, I'm a proponent of both, right? We always think it's not just when we have a known mood disorder. I always think it's important, like, if medication's going to help you, great, but make sure you also get therapy as well. And so I'm one of her fans. And so, I think it's a very important dynamic. And we know women and everyone does a little better when you've got both.
True.
And so that's important. But the challenge for us is that there's so many new medications out there, right? And that could be very efficacious. And the medications may be the same, except one thing changes on the medication. This group is all of a sudden here, whatever. There are slight changes in the medications, but they often don't test them in pregnant women or in breastfeeding women, right?
Yeah.
And so that is the, I would say, maybe the anxiety driving part of this. But before they come to market, there is at least some animal data or early human data that would suggest either way. And so if your care provider goes, well, this is a class C, where I can't tell you 2,000% that this can cause, but from what we have, the small evidence we have, we consider it safe, then it's a reasonable time to take that medication. So.
Yeah, those medications typically have been used for years,
Right.
Successfully, and they aren't usually prescribing some brand new medication, new on the market. It's something that's been used successfully for a number of years.
We
as
often
well.
have we have the tried and true for pregnancy too, and
Right.
Yeah.
with consult with Dr. Pawlak,
Yeah. And I think that therapy is definitely the first route, and also know that there are some of us that need the medication in order to get ourselves in the door to talk to somebody about what's happened, because it can be too painful to even discuss. And so, definitely, we advocate strongly for therapy with a qualified professional. And if that professional then thinks that maybe medication would help, that's great.
Mm-hmm.
So on a similar topic, we've already established that women cannot cause these things for themselves. But let's say that an expectant mother is feeling this sense of anxiety, and either her doctor or her family and friends are all saying, you're just not relaxing enough. You're just overly worried. What advice could you give to them to either get the courage to push more, to say, no, this feels more than just a little worry? So what advice would you give to those women?
I think it's really important to trust your gut, trust your instincts, and don't sort of be put off. You're going to know yourself better than anyone else is. It's very important to talk to people about what you're feeling. And yes, maybe, employing stress reduction strategies might be something that helps, but that might not really be the answer. So, really, like I said, trust yourself with that.
I would echo that. There's actually really good data on things like mindfulness training, right, and stress reduction techniques in the world of hypertension in general. So this includes men, women, not just pregnant women. There has been some improvement in acute physiologic changes. Their blood pressure kind of lowers. Sort of makes sense, if you learn how to meditate correctly, physiologically, your mind is controlling your body to do that. Now, the next step is not the next obvious question is, well, will that prevent preeclampsia? Well, there's not any data for that. But in general, the more that you can, reduce your stress, it's not a bad idea. And there's certainly lots of avenues by which to do that.
Mm-hmm.
Yeah, I think this is advocating for yourself. We certainly see a lot of cultural, religious pushback against therapies or medications,
Right.
and also just the stigma of mental illness.
Mm-hmm.
So you might have family members who have been told something about mood disorders or mental health that don't align with reality, and you just have to advocate for yourself and potentially your baby to seek the help that you do need.
Mm-hmm.
Yeah.
I mean, it's amazing how much that stigma is such a huge barrier to getting appropriate care. And so you said it, I'm not trying to mansplain you.
I know you are.
I'm giving you props. That's a perfect, and I think as a provider, it's very tough to get past that, whether it's social, cultural, whatever stigma it is around mental health. I mean, to me, treating your mood disorder is equally as important as treating your diabetes. To me, it's the same thing. It's another thing that we need to make sure we take care of to make mommy their best for their pregnancy, for them and for their baby.
Yeah, and I think it also goes back to this isn't something that you caused. So, by meditating and not stressing, you're not going to
Right.
not get preeclampsia.
Right.
You're either going to get it or you're not. And, it's good self-care to do what you can to relieve stress, but that isn't going to prevent preeclampsia.
So we've discussed a little bit how to manage fear and anxiety during pregnancy, but another concern for some parents is managing anxiety once they're home from the hospital. Yana asks, what are some strategies for not obsessing over stuff after delivery of a term baby after experiencing a NICU stay with a previous pregnancy? I am currently obsessing over how many milliliters my daughter eats, even though there's no need.
So Yana, yeah, anxiety, that's kind of what it does to you. When you have an experience like that was so challenging and difficult, like we said before, it kind of primes you to be on the lookout for all those little things that really probably aren't changing anything. I love doing deep breathing exercises when I feel anxious. I think that's a really good strategy to use. Definitely talking with your health care professionals to find out, how things are going. Getting some of that reassurance, getting some of that information and education can be helpful. I also really advocate talking to other women who have been through similar circumstances. I can't tell you enough how important that is in normalizing the experience that you're having, normalizing the feelings that you're having, realizing that you're not crazy, you're not alone. There's nothing wrong with you to have because you're having those feelings and fears. Some of that right there will help to reduce some of those feelings and make them dissipate. Just realizing that that's to be expected based on what you've been through.
So if now I could switch my role to being, instead of being the publicity agent for Dr. Pawlak, being the publicity agent for Kara Boeldt and her group. I mean, I think that absolutely, and I think women find strength from other women's experiences, and I think that's so important. I see it day in and day out. The challenge is to find a source, right? It's one thing when you're talking to your friend who may have had a similar experience where you know that person, but there are huge groups, such as Kara's group, that have this huge outreach. And what I appreciate as sort of a provider associated with that group is how evidence-based it is, and they do a lot of myth busting. I'm like, well, my job is being done by her. So
Yeah, that's really what our community is built on, is women finding that they're not alone. And with almost 21,000 members in over 100 countries, likely there is somebody who is like you, right? Or has had an experience like yours, at least close enough that you can find somebody to ask questions of, somebody who might be farther down the road than you. I'm 14 years past my preeclampsia experience, and my mental health experience with preeclampsia. So there's some of us that are just a little farther down the road who can help provide you some guidance and advice, and to the evidence base, turn you to, the studies. If you are asking a question that's, science based, we can point you to the right sources of information rather than you Googling something and freaking out over what you read. So we will guide you to the evidence base, and then, give you suggestions on how you can advocate for yourself and speak with your care provider.
So Sarah submitted a question about anxiety symptoms. She asked, what does anxiety feel like? Can it still be anxiety even if it doesn't feel like nervousness or I'm not shaky? And what are other signs that I might be experiencing anxiety?
This is a really good question. We see this a lot, where we might gently and with love reach out to one of our members and talk to them about whether they're seeking care for potential anxiety. Because I think that, and I'm curious your experience, that a lot of women don't realize they have anxiety, right? It doesn't feel like whatever they think it should feel like, or whatever they've seen it portrayed on TV. And so, we, having done this for over a decade, can see patterns in how people interact with our group, and that might be suggestive of anxiety or depression. But I'm curious also how you can describe that.
Yeah, so there's different types of anxiety, first of all, and there's within each different type of anxiety, there's a variety of symptoms as well. So one person having the exact same diagnosis as another person, their anxiety might look very different. A lot of the symptoms that we associate with anxiety are physiological symptoms, so rapid heart rate, difficulty breathing, dizziness, sort of like the physical things that you feel when you're anxious, like that adrenaline, fight or flight kind of rush. But anxiety goes beyond that. There's a cognitive component to anxiety. It's how you think about things. It can look like irritability. A lot of women will come in and say, I'm just so irritable all the time. It's not me. And that's their anxiety. That's what it looks like. So it doesn't always look the same from person to person. It can be very individual, and sometimes it looks different from situation to situation as well. Some different types of triggers or things that cause you to feel anxious manifests as maybe those physical sensations, and another time it's more your thoughts, your anxious worrying. You can't stop your brain from circling around and around. So it's really important to remember that, and it's good to look at some of those criteria, because maybe what you're experiencing is not anxiety, it's something else. But like I said, it doesn't always look the same from person to person.
And so I think what I heard you say is that there's not just a convenient list, and if you hit every single criteria, then you might get a diagnosis, but rather there are different criteria. You might meet some of them and not all of them, and it might be different criteria than your next door neighbor has.
Absolutely.
I think that's a question we get a lot. I don't think I meet all the criteria. But getting to someone like you can help them sort out what it is.
Absolutely.
I think one of the other struggles we have with anxiety is that some of those physiological symptoms, like you just described, the rapid heart rate, the trouble catching your breath, maybe is maybe similar symptoms to what they felt when they were really sick, critically sick with really high blood pressure. And so they have some like medical anxiety, like there's something physically wrong with me and I feel like I'm having a heart attack, right? Panic attacks. I've had a panic attack previously, and I thought I was probably dying. And I think that is a struggle. Am I having a postpartum preeclampsia experience, or is this anxiety because of my health? And I'm just going to ask a question of either of you. What should somebody do, and what are the what's the differential between, is this anxiety or is this something that I should go to the emergency room for?
I think even before you get to that criteria, I mean, and one of the things I was thinking about when you were talking is there isn't a list. There's not the list. As with everything in pregnancy, right? What are the most common symptoms that we talk about preeclampsia? Headaches, blurry vision, and abdominal pain and swelling. What do you get in normal pregnancy? Headaches, blurry vision, swelling, and abdominal pain. Yeah. So I think this is true in preeclampsia. It's true in mood disorders. That number one, you recognize something is wrong and call your provider. And I sound like a broken record, but my fear a lot, and part of the problem is that people like, I'm fine, I'm okay. Is there a criteria? No. If you don't feel right, call. And obviously there are things like when I feel like I've got chest pain. That's an obvious go to the emergency room. If I am having a hard time breathing, it could be anxiety, or it could be something else that could be as equally as dangerous or even worse. And so I think the important lesson to learn is don't doubt yourself. Call your provider, and that's going to be the end of my broken record. Probably not.
Well, and I'd like to have some clarification. I know that you sometimes are on call, right? Yep. And we have a lot of women who are like, I don't want to call my doctor because it's Sunday and it's midnight, right? Yeah. Are you working on Sunday at midnight if you're on call? Yeah.
Right. And so
and
it's particularly in large centers like this, there's always a physician, there's always a care provider 24/7. There's always a labor and delivery number. There's always somebody there that if you have any questions, you have a health professional right there, and we'll tell you, well, there's a reason why we've all been educated in our particular fields, right? And that is to be able to do the differential and let us help you kind of find whether it is appropriate to go to the emergency room, or if talking with you, it doesn't seem as severe, maybe come in and see us in clinic the next day. But the important thing is to advocate for yourself and just call. And I think that once you get past that activation energy and that barrier, I think a lot of these things can, people just don't want to call docs. I mean, that's why we're there. We're there 24/7. I mean, call.
Yeah, you and your baby are just so very important, and it's better to err on the side of caution. I'm always telling women that you're not troubling someone, you're not bothering someone. It's important to ask for your own reassurance, and with the possibility that it's something more than you really realize that it is. Finding out from a professional sort of what's going on, that's never a bad thing to do. Worst case, you find out you're okay. It's anxiety or it's something else. It's not a medical emergency, but why not find out?
I love that you brought that up. Don't find shame in when we say it's okay and you're okay. It's our job to make sure, and your symptoms are real, right? We validate your symptoms. What you're experiencing is real. Our job is to make sure that what you have isn't something life-threatening right then and there. And then if you have long-standing anxiety, and it's truly that, let us help you get to that. So and so if someone, I hear it so many times in labor and delivery, well, I didn't want to come in because I didn't want the doctor to tell me I was stupid. I'm like, you're not stupid. You have these symptoms. Let us help you.
Yeah. And then I think if you find yourself in the emergency room 7 times in 2 weeks, and you've been cleared, that's when it's time to go talk to Dr. Pawlak, right?
Yeah.
So I think that's a good way to maybe distinguish.
Mm-hmm.
Yeah.
So the last question for this section is, can you explain to our viewers how perinatal diseases like preeclampsia can be affected by or influenced by mental health issues and vice versa?
So it's interesting. I spend a lot of my time in the lab, and so I do a lot of as a researcher, looking at humans, looking at mice, looking at rats. I give mice preeclampsia, and so I fixed it. So if you're a mouse out there and you have preeclampsia, I can cure you. But the problem is that a lot of the real mechanisms and the things that sort of we think cause preeclampsia is overlapped by similar mechanisms that are being contributed by mental health disorders, right? And so, and this is where it's really important to kind of get the idea of causation versus association. Just to talk a little bit about data, there is a lot of data, particularly in the hypertension literature, but also in the preeclampsia literature, that if you have a history of a mood disorder, that you're at increased risk of developing preeclampsia. Doesn't mean you'll get it, but it's associated with a higher incidence of preeclampsia. With the other way around, if you have no mood disorder and you have you get preeclampsia in the middle of your pregnancy, that experience is enough to maybe unroof a mood disorder like depression, anxiety, PTSD. And so from the standpoint of what can we do and to fix the cause, it's very complicated. But to get to the point where I say that having depression literally causes preeclampsia, I think is a big jump. But they're certainly associated for sure.
So this would be like another underlying disorder, right? So
right.
If you have type 1 diabetes, you might be at a higher risk of developing preeclampsia
right.
than someone who doesn't have, type 1 diabetes.
I think you guys, it's like another risk factor, right?
Yeah.
Mm-hmm. What are common risk factors for having a heart attack for anybody? Already having hypertension, diabetes, already cardiovascular disease, so obesity, anything like that. And so yes, it's another risk factor that may lead to it.
Okay, so if you're just joining us, we're here with high-risk OB doctor and preeclampsia researcher, Dr. Mark Santillan, clinical psychologist and director of the Women's Wellness and Counseling Service, Stacey Pawlak, and patient advocate and president of EndPreeclampsia, Inc., Kara Boeldt. We're discussing maternal mental health before, during, and after pregnancy. And this is an interactive video, so please feel free to leave us a comment with your experience with mental health, preeclampsia, or other perinatal disease in the comments below, and please let us know where you're watching from. Stacey, this question is directed at you, but the others, please feel free to chime in as well. Can you tell us a bit about the women's wellness services offered here at our hospital and what women can get out of those services?
Absolutely, I'd love to. So our clinic has been around since 2007. I think we're a really awesome and unique collaboration between the psychiatry department and the obstetrics gynecology department. So we're psychiatrists and psychologists and students in those areas and residents, but we really get all of our referrals from OB-GYN, and we're really unique also in that we provide both mental health care in terms of medications as well as psychotherapy, which is pretty rare. There's not very many places really across the country, and I don't think any others in the state that do that. We are great not only in clinical care, I believe, but we provide a lot of training to resident physicians, to fellows, to medical students, to doctoral and master's level students who provide psychotherapy services. So we have some really great options, and our focus is on perinatal care, but we also work with women across the reproductive spectrum. We have a specialist with menopausal and perimenopausal issues. We have someone who works with PMS and PMDD. We have a new chronic pelvic pain clinic that we're collaborating with OB on, so lots of different things like that. And we have specialists within our program also, so my specialty area is infertility and perinatal loss. So, yeah.
As a referring provider, they are essential to what I do because many of the comorbidities like diabetes, hypertension, all of these things, and recurrent preterm labor, pregnancy loss, all of these things, almost always when I look at a patient's problem list, it's our OB stuff and then anxiety, depression. It's always on that list, and we're not the experts. We're happy to help, but really Dr. Pawlak and her team are the experts in all of this. And again, we're very much a fan of both psychotherapy and medications because we think people do better. And so there's a lot of expansion in your clinic that's happening too. You maybe there's an opportunity for telemedicine maybe eventually.
Yep, that we really feel that's sort of like a direction that things are going in, especially in this state where a lot of our patients are not close to us, not close to a specialized mental health care provider or physicians even. So there's really a shortage of people that can provide the care that we provide. So we started a pilot grant. Our department gave us a pilot grant last year that's providing both medication services as well as psychotherapy services to women in a telehealth format. And then we're hopeful we're partnering with OB-GYN with their huge, really awesome grant that they received from HRSA, and that's going to involve even more in that area of telehealth. So that's one of our initiatives. One of our psychologists also recently started a program in the antepartum unit. So for we don't do a lot of inpatient work, but she's going to be, she goes to the antepartum unit visiting with women who are possibly hospitalized due to preeclampsia or multiple gestation, something like that. And she's providing like on-the-spot interventions, some crisis services, some brief therapy. So that's another great thing. And we're also hoping to bring brexanolone to the hospital. Yes, we're working on it. It's taking a while. That's a newer medication.
Okay, I was just going to ask, what is that?
Okay, so it is a new medication that's used for postpartum depression, generally more severe postpartum depression. It's going to be for women who maybe tried medications, tried therapy, and still aren't seeing an impact. And it's almost miraculous. It works very quickly. And it has a lasting impact on reducing those symptoms. And so for women who don't have relief from other forms of treatment, it's amazing. It's very expensive though right now. That's one of the issues why it's not widely available. It was just approved by the FDA, I believe last June. So we're working hard. We feel like any tools in our arsenal to provide to women with mental health issues, we want to be able to do that. So we're super excited about all these different programs and more that we're working on.
So I heard you say you have some patients who are calling in and having treatments, having therapy across the phone from maybe more rural areas where they don't have access to a care provider. So you're piloting that
It's
program.
a really small grant. Yep, that one we're looking at sort of like we want women to be a distance away, you know. And a lot of times these might be women who we were seeing here for treatment, say someone whose baby was in the NICU. So while their baby was here, we were meeting with them here, but then they go home and now what do? They don't have a provider near them. Maybe the baby really shouldn't be going out in the winter weather. Baby has special health needs, things like that. It's hard to get in to see a provider, but they still need that continued care. So moving forward, we hope to sort of expand that so it's not just someone who's far away or baby is sick, but just because they need that service.
Yeah, I think it's really hard when you have, I had a preemie, you have 150 doctor's appointments for your baby, you're not feeling well yourself. I had a baby in the winter, that made it harder as well. For us to just, even get out of the house, it can take 3 hours to pack up and take everything you need to get somewhere. So it becomes more of a stressor to go out and seek the therapy than it is to just stay home and try to deal with it. So I think that's a really amazing program that you're piloting, and I hope that it's really successful and it gets better. And the antepartum work, for our community, a lot of those women do. They, especially if they've had a previous experience, or even if it's brand new, they're sitting in the hospital and they have nothing to do but worry, right? So to have somebody who's coming to talk to them on site would be a game changer, I think.
One of the services we have here at the University of Iowa is we have something called the Butterfly Brigade, and these are women who have been on our antepartum service. So they've been admitted, they've been inpatient for long periods of time for lots of different perinatal issues, preterm labor, PPROM, or rupture of membranes, preeclampsia, what have you. And these are people that have lived the life, and then now they have a NICU baby. So they've lived the life, they know what's going on, and our services here is that we have volunteers that donate their time and their effort to sit and talk with our women in house to kind of share their experiences, because again, women find strength in these stories, and I think it's really important.
Yeah, knowing they're not alone, knowing they're not the first for these sorts of things to happen. Yeah.
So how does one choose a mental health provider? And once started with therapy, what should people expect from their therapy experience?
Yeah, I think that's a really good question, and it's important to kind of think about what you're looking for, what you would be looking for in a clinician. What are the symptoms you're experiencing? What are your goals for treatment? Thinking about those things, sort of preparing yourself before you go and meet with someone. If you feel like, well, I really have postpartum depression, I really need to deal with this. There are evidence-based treatments for depression. There are evidence-based treatments for anxiety. An example, like for, let's say, PTSD, cognitive behavioral therapy, or EMDR. Those are two treatments that have been shown to be really, really effective with PTSD. So when you go and look and sort of are looking around at therapists, finding one that sort of has that experience or that skill set or that training is going to help you to find someone who can help you. But then I really want to tell people that therapy is a relationship. It's not a friendship. It is not like any other relationship maybe, but it's a relationship. So you may find someone who has credentialing in the type of therapy you think is going to help you, or experience in that area that you want to deal with, whatever it might be. But if you don't actually feel connected with that person, you don't feel like they hear what you're saying, or you aren't able to, you just don't feel comfortable with that person, that's extremely meaningful. I suggest to people, talk to that clinician, because this isn't a friendship. You're not going to hurt their feelings when you say, that wasn't very helpful for me last week. I tell people that all the time. Let me know if what we talked about wasn't helpful, or did we forget something that you wanted to discuss, or what's the direction you want to go in. That's what you need to be prepared to go in and meet with when you go and meet with someone. And also have an idea of your goals. You want to be working on stuff that's important to you. I think it's hard for people who have never been in therapy to know what to expect.
I think it's one of the biggest challenges to get their foot in the door, honestly.
Yeah.
They have no idea what to expect, or how, traumatizing that experience is going to be for them. What does that look like? So I think talking about, the different types of therapies is really important.
Yeah. And there are some really good guidelines for people who maybe haven't been in therapy before. You can find them on the American Psychological Association website, where it says like what to expect from therapy. How do I know if therapy is working? Things like that, because how are you going to know? And I will say something too, like even if a friend recommends a therapist or a clinician or a psychologist, that doesn't necessarily mean that will be a good person for you. They may say this person was great, they changed my life. They may not be that for you. Hopefully they are. You can try it out, but it's also good to realize that sometimes you need to switch to a different clinician. And I'll tell people it's the same thing as well, and say if you feel like this isn't working with me, I can help make a referral to someone else. I'll find you someone who meets your needs. So if you kind of know what your needs are, you know what you're looking for, that helps, but I can help you too.
So if they don't, I know a lot of women don't know what their goals are. They don't know what's going on with them.
Yep.
They can still walk in your door without a plan, without being prepared,
Sure.
and you're going to help them sort that out.
Absolutely, yep.
Okay.
So that's part of our training. We help people to figure out what it is they're looking for. I might say, so we met last week and we talked about these things. What was meaningful to you? What resonated? And what was sort of like, that really didn't help that much. So that gives me clues as to what we want to do moving forward, what type of treatment we want to use. Some people really want to come in and build skills. They want specific strategies to help them feel better. They want their symptoms to decrease. Some people really just want to find a place to talk about things where they're not judged or censored for how they feel. So that's part of my job, is to tease that out, to give you examples. And it can be super, super stressful to come in for the first time with any person and meet some new person, but especially in a situation where you're talking about maybe your fears, difficult things, stuff you maybe never talked to anyone else about, traumas you may have experienced. You should feel like that person sitting across from you is listening, is caring, wants to help you, has the tools to do that. And if you don't feel those things, don't go back. Go find someone else.
It's got to be a very vulnerable place to be able to expose yourself to someone else with something as deep as a mood disorder. And I think part of that is, and again, my job on this panel is to be the broken record. And in terms of, if you're feeling that way, tell somebody, tell your healthcare provider, because I may not directly know the answers, but I have friends that do. And so it's a matter of just getting yourself to that front door. And it's hard. I know there's been a lot of people where in the back of my mind, I meet them in the beginning of their pregnancy, I'm like, we start talking about women's wellness, and they're like, we think you maybe would benefit from this. And there's a big barrier to just getting over this stigma of mental health. It's just as important as preeclampsia or any other perinatal disease.
Yeah, I think what we see are women are, they may feel like they were brushed off with the symptoms they had, maybe in a previous pregnancy or even current symptoms. And so they want you to fix them, before they go see Dr. Pawlak, right? And so having that conversation of and being open about what are the symptoms and what is maybe, hey, everything's right, we did all your blood work, we did all of those things. We really do think that the next best step for you is to also go see, as part of your care team, the Women's Wellness Center. Mm-hmm. On the flip side of that, we have women who their doctors are, you just have anxiety, you're just too stressed out. This is sometimes we see this with families as well. And then they send them on their way without making a referral. Mm-hmm. And so they then feel brushed off, sure, like anxiety or stress is something they should be able to control or manage on their own, which feeds that stigma. So, it's kind of a hard, I'm sure it's a really hard line for you, how is that person feeling about this referral you're going to
sure
make, or whether you should, make a referral. And I would say, as a patient advocate, if your doctor has said, this is some anxiety showing or some depression or whatever it is, ask them for a referral. Thank you for letting me know that you think this is anxiety. Who can I go see to sort this out? Because if it really is an anxiety issue, then talking to someone can definitely help, and then hopefully you will, as the patient, feel like you're not being brushed off, like you are getting the care that you need.
Well, I think one of the realities too that sort of is really challenging for referring providers is there often aren't, especially in perinatal mental health care, there aren't places to send your patient to.
Right.
So you may
Absolutely.
do the appropriate screening. You may know that a referral is in line, but it's like, now what do we do? And that's really unfortunate. I don't know what the answer to that is, but it puts people, you're in a bad position as a referring provider, like, what do I do here?
Right.
So that's a big challenge.
It's a huge challenge, and I mean, as you mentioned before, expanding your services even through in our rural state of Iowa is really important. But this is not just endemic to Iowa.
Right.
This access to appropriate mental health care.
Right.
This is throughout everywhere in the United States, and I'm sure well beyond that. And so I don't have an answer. I mean, it's a philosophical question, but the answer is, for us, for those of us that are entrenched in treating women, it's just as important. So, find somebody, call Dr. Pawlak. Her phone will ring off the hook. 555. Can we put that underneath to hit this link? Because I think it would be important to at least, there would be, a lot of times I get a lot of calls about, like, hey Mark, I live in New York. Who's really good about, my concerns about preeclampsia or something like that? I have friends. Dr. Pawlak also has a lot of friends who
That's
are
right.
professionals, so we could at least get you to a place where that might be more equipped to deal with your symptoms.
Yeah, we send people to Postpartum International.
Yep.
They have telephone services where you at least talk to someone right now if you're feeling a certain way. And they have online services you can find wherever the nearest, clinician, therapist is to you. Even if that's, a driving distance, you can still find some resources and get some help, especially immediately if you're feeling like you're maybe going to hurt yourself or someone else. That you can pick up your phone and call them. It's a really great resource as well.
And on the positive side, I mean, so like you mentioned Postpartum Support International, we have a new Iowa chapter, and that's one of our goals, is to bring more trainings to our state that train providers in being able to provide care to perinatal women. So it's, there is movement in that direction. So
Yeah,
there's a recognized need for sure.
Yeah, and I think access due to cost concerns is also a challenge. So, talking with them and finding resources, talking to your care provider, right? They might have a resource for you that maybe wasn't, you weren't aware that existed, so.
Mm-hmm.
So our last question for the evening was submitted by Alexandra, and it's specifically about preeclampsia research. So what kind of research has been done, and what does the future look like in regards to a cure for preeclampsia? And are preeclampsia and autism linked at all? Have we found that in research?
It's a lot of questions.
Wow. We're
I
gonna
saved
take-
this for last because it feels loaded.
We're going to take the next hour. No. The answer is I'm very optimistic. And the quick answer is yes to your last question. So let me back that up a little bit. So there is a lot of research in the realm of preeclampsia. And if you just Dr. Google preeclampsia, and Google Scholar has a whole bunch of papers that come up, there are, it's amazing in the field of preeclampsia. The more you know, the more questions you have. And so not only from the very molecular basic science, I'm holding up my pipette or working with a mouse end, to the actual treatment of preeclampsia, there's lots of work doing it. I think some of the more recent advances that are kind of driving clinical practice are kind of earlier markers of preeclampsia as a predictor, and then trying to use our new preventative agents. So currently, the one preventative agent that we have in the world is baby aspirin for those at risk. Can we identify even people at even higher risk of developing preeclampsia so that aspirin is a more effective preventative? There are lots of work, not only outside of the biomarker field, but looking at preeclampsia more than just a cardiovascular disease. It's an immunologic disease. And there's an amazing amount of literature out there that if you looked at the genetic makeup of placentas from women who have preeclampsia, the simple clinical description of either preeclampsia with severe features and preeclampsia without severe features get thrown out the door. Maybe what we really have is a spectrum disorder with 5 types of preeclampsia, not just 2.
So we call the flavors of preeclampsia.
The flavors, it's exactly
of
what.
preeclampsia.
And the more that I do research, the more we feel like it's a lot like Baskin Robbins. It's like it's like the 31 flavors. We're not sponsoring them. It just so happens. And so these mechanisms that we're looking at are, everything is connected. You are a person. You are not a mechanism. You are not oxidative stress. You're not an you are a person. And so everything is so integrated, and to be able to pull those things apart and to try to figure out what causes what in the flavors of preeclampsia gets very difficult. And so I love that last question of autism leading to preeclampsia or being associated. Absolutely. So from the epidemiologic standpoint, we know that women who have preeclampsia are at increased risk of having babies with a neurodevelopmental disorder like autism spectrum disorder. And so I am actually working with a mouse model, that in my mice, that in the pups born to those mice with that model, later on they develop mouse anxiety, mouse cognitive disorders. And so, and we're doing this work with a collaborator here at the University of Iowa. There's lots of data associating those two things. So great question, and stay tuned. Is there going to be a cure? To something, yes. But the more we look, the more we realize that preeclampsia is more than just mild and severe.
I think there'll be probably multiple strategies to buy women time to ensure that they stay healthier longer, that babies have a chance, and depending on how many flavors there really are.
Right.
Maybe some of them have different I guess strategies to manage them.
And again, it's from new medications to new preventative agents, or using old drugs to as a new preventative agents. There is a whole, in fact, there's a world of data trialing statins, so lipid-lowering drugs, in the prevention of preeclampsia because it has some off-target effects. And so there's lots of data around that. So again, it's an ever-changing field, and it's very exciting. So stay tuned.
I think another important topic or discussion point on that is that we often see women who are like, I did a certain thing, or I ate a certain thing, or I took a medication, and did that cause it?
Yeah.
And we always, go back, or could I have prevented it? And, there's a whole bunch of really smart people like you, right, who are researching and have been forever, like,
I'm not that old.
well, not you.
Oh, okay, sorry. Okay.
But, more than 50 years, right?
Right,
You
right.
can look back and see,
Right.
research that's very old. And if it was something as simple as doing a certain thing or not doing a certain thing, you would have uncovered it by now.
Right.
Right?
That's a great perspective, right?
Yeah.
If we wouldn't be talking about it if we found the answer, right?
Right. So it's really complex. It's really complicated. You didn't do anything to cause it. There's not something that you could have done to prevent it. Even preventative agents now, right? They're not 100%. They don't work in everyone. They work in certain people, certain times, and so this is not your fault.
To get to that, I mean, if you go to Google and say prevention and preeclampsia, a million things will come up, and they're like, sometimes it works, sometimes it doesn't. And so
And sometimes it works, and then they studied it more, and
then it doesn't work. It doesn't
Yeah.
work all of a sudden. So that gets
Yeah.
confusing. And so you're right. And she's taken over my role as the broken record, and it's like, it's not your fault, and it's just because you didn't do mindfulness training, or you didn't take vitamin C, or you didn't make sure your calcium up. It's not your fault, and we're still trying to figure it out. So.
Right. Well, thank you so much to Dr. Mark Santillan, Stacey Pawlak, and Kara Boeldt for discussing this important topic with us tonight. And thank you to everyone who watched this live broadcast and submitted questions. If you tuned in later, make sure to go back and watch the full video. And if you're interested in learning more about our women's wellness and counseling service or any of the other resources discussed tonight, we'll include some links in the comments of this video for you to find out more about those things. You can also learn more by visiting www.uihc.org. Thanks again for joining us, and have a great rest of your night.
Good night.
Thank you.